there. Welcome to today's chat, Health Stories Project. I'm the host, Susan Branzel, and we're going to be talking today about stigma and lung cancer. Is this the first time you've watched? We'd like to hear from you if so. So comment. You can comment on your screen, and we can keep track of who has been here before and who has not been here yet. So thank you for letting us know. Before I start, I want to let you know more about Health Stories Project. We connect people with opportunities to inspire, educate, and support others by sharing their health experiences. So members of our community can get to participate in all kinds of interesting opportunities, including video projects, live speaking events, blog posts, videos like this one, and more. So we really encourage you to sign up for our community. We welcome anyone with any health condition, of course, including lung cancer, which we're going to be talking about today. And if you're interested, please just visit our website, healthstoriesproject.com. Great. Now we're going to get started. Today we're talking with Dr. Lisa Carter-Harris, who is from Indiana University. Lisa is a behavioral scientist and a nurse practitioner who studies ways to reduce stigma about lung cancer. Hi, Lisa. Great to have you here.
Hi, Susan. Thank you for having me.
Absolutely. During Lisa and my conversation, I encourage our viewers to ask questions, and we will and share constructive comments if you have something you want to say, and we will answer them as soon as we can. So thank you for engaging in this. We want this to be a multi-directional conversation. Please keep in mind that anything you hear today is not considered medical advice, and if you have questions about your health, you should always consult your healthcare provider. All right, Lisa, let's get started for a second. Really, I'd like to start off by talking about what stigma is, make sure everybody's on the same page. How would you define stigma?
That's a great question. There are some pretty consistent definitions that have been around for a long time, and they involve words like tainted or disgraced. But I think of stigma as anything that makes a person feel less of a person in some way because of either a disease or a lifestyle choice or anything at all, but making that person feel less than a whole person.
Okay. So one of the things that we know is that lung cancer is often a stigmatized condition, and I know that's something you've looked into deeply. Can you talk a little bit about why specifically lung cancer is stigmatized?
Yeah, so unfortunately, lung cancer became very stigmatized in direct relationship to our efforts to promote smoking cessation. Now, don't get me wrong, smoking, I don't advocate smoking. Smoking is detrimental to your health. As you said, I'm a nurse practitioner, and we should support people in ways that they can try to quit this very addictive act. But unfortunately, as decades ago, when we started ramping up our efforts to decrease smoking and to promote smoking cessation, we unintentionally demonized tobacco, which demonized lung cancer. Lung cancer is the primary cause of lung cancer, or risk for lung cancer is smoking. But in addition to that, other things. This led to people viewing lung cancer as something that somebody caused because they smoked. It's very interesting if you look historically at how smoking used to be very sexy. It used to be on the big screen. It used to be something that was a rite of passage. I mean, everybody smoked.
Right, it was glamorous, right?
It was glamorous. I mean, you watch old movies and you see everyone smoking, and you even had doctors and dentists and Camel cigarette ads in the magazines. And now because we know everything that we know about how smoking and nicotine affects the health, we really have moved toward trying to promote tobacco treatment and smoking cessation. But with its link to lung cancer, that has really increased a feeling of blame, and for some people, some internal shame. And that comes both internally and externally. Some patients who've been diagnosed with lung cancer unfortunately feel like they deserved it because they smoked, or they fear talking with others because people make comments that, well, why didn't you stop smoking long ago? Or you deserve this because you engaged in this behavior. And no one deserves cancer, regardless of whether it's lung cancer. Nobody deserves cancer.
It's a pretty powerful statement, Lisa. Thanks. One of the things that you alluded to a little while ago when you were speaking was really that not everybody who gets lung cancer has actually smoked. So, in addition to the fact that nobody should be blamed for causing cancer, can you talk a little bit about sort of the stigma differences experientially between people who have smoked in the past and have lung cancer and those who develop lung cancer for other reasons?
Yes. So one of the things that I always like to say is if you have lungs, you can get lung cancer. In the course, as you mentioned before, I'm a behavioral scientist, so I do a lot of research. And in the course of the different studies that I've conducted, 25 to 30% of participants who had lung cancer were never smokers.
Mm-hmm.
And so there are different reasons why people get lung cancer. There is a genetic component. There's also exposure to radon. Radon is an odorless gas that leaks from limestone. I'm actually in the state of Indiana, and both the state of Indiana and the state of Kentucky have very high levels of radon, and that's the second leading cause of lung cancer. And so it's something that you have to acknowledge, that it's not just a smoker's disease. And because the public's perception many times is that it is a smoker's disease, I think that that propagates the stigma. One of the things that I've always thought was really interesting, when I would have participants in my study and we would talk, if they were diagnosed with lung cancer, and we would talk about their lung cancer, the very first thing that would come out of their mouth if they were a never smoker is, I have stage 4 lung cancer, but I never smoked. It's like they wanted to legitimize it for me, so that I wasn't judging them. And so to me, that was really frustrating, not for the patient, not from them telling me that, but that was frustrating because they had felt they had to tell me that.
Sure. So, one of the things that we know is that stigma really can affect people's behavior, people's health behavior. So can you talk a little bit about how the stigma of lung cancer affects health-seeking behavior, interactions with healthcare providers, that kind of thing?
Sure. One of the things that we found in a study that we did several years ago was that people who had lung cancer, many people would delay seeking help for symptomatic symptoms. Lung cancer is generally considered a silent disease, that you don't have symptoms until it's late. But many of the participants in my study did, when they looked back on it and we were talking about their health trajectory, they actually did have symptoms. I've talked with people who were coughing up bright red blood and didn't go to the doctor because they knew they were a smoker, and they were worried about being told, either, you deserve this, or feeling internally like they deserved it because they had made many quit attempts before and weren't successful. That I think epitomizes the experience of someone who is scared to go to the doctor to seek out treatment for symptoms that they're concerned about because they're worried that they're going to be blamed for having smoked. It also has impacted, we have lung cancer screening now. It impacts people even wanting to bring up that conversation with their doctor because, number one, it admits out loud that I'm a smoker or that I qualify for this. And maybe that's not something that I wanted to say. I have to interact with a lot of people in the healthcare system, not just the doctor, the nurse. If I go to get a scan, or the radiology tech, are they going to make me feel bad about it? I'm not saying that this affects everyone, but it affects enough people that I wish that we could get to a point in where I don't have to have this conversation and stand on this soapbox, that we could change the public conversation around lung cancer.
Lisa, do you do any work with healthcare providers, or do you know of anybody who's doing work with healthcare providers to improve how they communicate with patients who are potentially at risk for lung cancer?
Yes, so there's a lot of work that is coming out of Memorial Sloan Kettering. Smita Banjan and Jamie Ostroff have been working with shared decision making in particular, and they have a passion about, Jamie Ostroff in particular has a passion about lung cancer stigma and educating healthcare providers, as well as Heidi Heyman, who is at the University of Arizona, and Jamie Stutz, who is at the University of Kentucky. They're all involved in work with both lung cancer screening, lung cancer patients, lung cancer survivors, as well as the importance of addressing stigma. And part of that is it's a two-way street. It's not just patients alone, it's also educating our providers. When it comes down to it, being a clinician myself, I don't believe there's a clinician out there that intentionally goes in and says, I'm going to try to stigmatize you. I think it's an implicit bias, and it's something that the person is not even aware that they have that bias, and that comes across in their actions. So really treating that or addressing that with providers is really increasing their awareness of how this affects their patients, so that they can better communicate with their patients that in a way, and framing messages that don't stigmatize.
Sure. So we never want to put the burden on the patient, especially in the case that they might already have a health condition or be worried that they have lung cancer. But do you have any recommendations that you might give to people about how they themselves can reduce stigma when involved in conversations about lung cancer if they have it, or with their provider if they're worried they might have it?
Yeah, I'm a big proponent of hitting it head on. I think because I feel strongly and know lots of wonderful providers, and don't think that this is intentional. I think that if a patient was to advocate for themselves and say, hey, the way that you've said this, or the conversation that we're having, or the way that it's leaning is making me feel bad about my disease process, and calling it for what it is. I have a feeling that if you did that, your provider would pull back. I don't think it would be negative. I think it would actually be enlightening for the provider, and empowering for the patient to take ownership of that. I also think that if they, caregivers or loved ones that go with you, helping to stand up in situations in which they feel like the patient is being blamed or made to feel badly, is a good thing.
Yeah. Yeah. Okay. Well, it sounds like it takes some courage on everybody's part to be upfront about how that conversation feels.
Yes.
Great. Lisa, can you just talk a little bit about your current work and what you're working on in your research?
Hmm. Okay, so we've got a couple of different things that we're looking at. We have a study that's currently funded by the National Cancer Institute, and we are looking at I've always looked at the patient perspective of lung cancer, and so what we're doing is we're looking at the different variables, and one of the variables we're looking at is stigma. We're looking at stigma. We're looking at medical mistrust. We're looking at cancer fatalism, cancer worry, and cancer fear. And what we're looking at is to see what makes people screen versus not. Are those things like stigma and mistrust and fear things that would keep people from screening, or do they screen anyway? And what we're most interested in finding out is, are the people that everything in their surveys say that they wouldn't screen, but they screen anyway. Why is that? We want to understand. Or everything in their survey says they would be a screener, but they're not. So we want to understand: are there components to this whole process in lung cancer screening that we're missing? Because when it comes down to it, we can't treat lung cancer screening like colorectal cancer screening or breast cancer screening. We've learned lots of wonderful information from that, but this is a totally different population, and we
Can you say
have
why can't we treat it the same way as the other cancers you mentioned?
so breast and colorectal cancer screening are primarily age and gender specific. Um, and it's something that mass screening is the goal in some cases. But with lung cancer screening, you qualify because of the fact that you not only your age, but you smoke. And smokers are a vulnerable population because of that stigma. And so we need to approach these conversations and the framing and the messaging of those conversations very differently than we do about breast and colorectal cancer screening.
So basically what you're saying is we blame people for getting lung cancer, but we don't blame them for getting colorectal or breast cancer.
Absolutely. One of the risk factors for, and this is going to sound really silly, but one of the risk factors for breast cancer is not breastfeeding. But do we ask women who get breast cancer, did you breastfeed if you have children? We
Mhm.
don't do that. We don't stigmatize people for, if somebody comes and tells you they had a heart attack, we don't say, oh, did you eat red meat and did you not follow a vegan diet and run 3 times a week? We don't do that, but we do that with lung cancer. We look at
Mhm.
people and we say, you smoked or you must be a smoker. And that's wrong.
So, Lisa, one of the things you referred to that I think a lot of people might be interested in hearing about briefly is what is lung cancer screening? Because we know more about other types of cancer screening. Mammography is very well understood, and colonoscopy, people know that's something they start getting when they're 50. But can you talk a little bit about lung cancer screening? Because I don't know everybody is familiar with it.
Yeah, and that's actually you bring up a great point because less than 4% of the nearly 7 million people who qualify for lung cancer screening in the United States have been screened, and less than 10% have had a conversation with their doctor about screening. So lung cancer screening is a low dose CAT scan of the chest. It's actually very simple. You don't even have to change into a gown. You lay down on the open domed machine. It takes less than 10 minutes to have a scan of your lungs. And with that scan, what they're looking for is are nodules or suspicious nodules or lung cancer in this case as well. This is something that's been a recommendation since 2013. There's a lot of controversy about it because the low dose CT provides such high images. And if you think about it, the people who qualify are people who are age 55 to 80. Currently, the current qualifications are 55 to 80. They are either current smokers or former smokers that quit within the past 15 years. And they have a really heavy long term smoking history. So if you scan a person's lungs that has smoked for a very long time, it's likely you're going to find something. So there's a very high false positive rate. And that's why it's really, really important for people to engage in a discussion with their doctor or nurse practitioner about lung cancer screening and if it's right for them.
Thanks for taking time to describe that. I'm really glad that you brought that up. We have a number of people asking questions right now.
Sure.
So we'd like to throw a couple questions out there. So some people are asking about secondhand smoke. Casey Ann says, I've always heard that secondhand smoke can cause, I think she probably means lung cancer. Is that fact or fiction? Can you speak to that?
That is definitely increasing your exposure through secondhand smoke increases your risk for cancer, lung cancer in particular. At the currently, we do not have a test. The lung cancer screening does not include people who are exposed to secondhand smoke. But yes, it is definitely a risk factor. And so when people are focusing on tobacco treatment with patients, if they are married or in a family, they try to make sure that's one of the incentives is decreasing the risk for not only yourself but your loved ones. But great question, Casey Ann.
So another question that comes up, Lisa, actually has to do with other kinds of discrimination and race and ethnicity. Can you talk a little bit about how that plays into stigma about lung cancer?
How race and ethnicity play into
Yeah,
that.
yeah.
So that's something that we're still learning a lot about. I currently have a study right now where we're looking at disparities in lung cancer screening behavior, and what we've looked at specifically is race and ethnicity, geographic location like rural versus urban individuals, as well as gender. What we found in our preliminary work is that gender doesn't seem to matter, but race and ethnicity do, as well as geographic location. And so African Americans tend to have less knowledge about the fact that screening exists and therefore are being screened less. And why that is concerning is that it doesn't allow us to be proactive. We know that when a cancer screening test comes out, that there are disparities between whites and blacks on mortality rates. And so, if we already are behind the curve with educating and even letting people know that this test exists, we're propagating those disparities. And so, one of the things that I would like to do with the data that we currently have is develop tools that would decrease those disparities and address that for all.
Does lung cancer affect different races and ethnicities differently?
It does. So, but it's actually tied a little bit more to the smoking rate. So, African American men tend to have higher mortality rates with lung cancer than African American women. But
So they
African,
die more easily from it, just to translate higher mortality rates.
yes, I'm sorry.
No, that's
Um,
okay.
but that's also related to the fact that African American men smoke more, and African American women have the lowest smoking rate when you compare that.
Okay. Okay. Another question that's come in is actually about family history and screening for lung cancer. Can you answer Shelley's question, which is if she had a parent with lung cancer, should she get screened earlier than normal?
No, it's if she doesn't have the if she doesn't meet the criteria from the perspective of being a smoker, a long-term smoker, and having that pack year history, which is a 30 pack year history. And what that means, if you want to figure out your pack year, is you take the amount of packs of cigarettes you smoke per day times the average number or the total number of years that you smoked to figure that out. So even if she's had a parent that has lung cancer and there are genetic components, it's if she doesn't meet the criteria from a smoking perspective or an age perspective, she should not be screened at this time.
Lisa, one last question for you before we wind up. What can people who are family members of people either with lung cancer or who are smokers do to help reduce stigma? I know we've talked about healthcare providers being able to help. I know we've talked about patients advocating for themselves, but there may be other people in the community who would be able to help reduce stigma about lung cancer. Do you have any advice there?
Yeah, I think the biggest thing is that we need to change the public dialogue about lung cancer and lung cancer stigma. I think we do a really good job. There's a hashtag called it's hashtag LCSM. It's lung cancer social media, and a lot of really active people that are involved in both the professional community as well as the advocacy community. But I think we need to take that further. I think that we need to leverage social media, not just with Twitter, but Facebook, Instagram, Snapchat, and really change that social conversation around lung cancer. I think that if you can change if we can go from it being glamorous on the big screen and that social conversation changing to being stigmatized, I think we can also do that by leveraging not only the public media but also the social media platform. And I think we all have the power to do that. The more that we talk about it, lung cancer kills more than 160,000 people every year in the United States. So that means that anybody that you talk to, has either been touched by lung cancer with a family member or a friend or someone that they know. And the more that we have this conversation and the things that you're doing, like this Facebook Live interview, and bringing awareness to the fact that if you have lungs, you can get lung cancer, and that we do not need to stigmatize people for a lifestyle behavior, a lifestyle choice. I think that that's where we need to take that's the direction that we need to go.
And that's pretty, sorry, I didn't mean to cut you off. Go ahead.
No. I was just going to say it's amazing that this has already been 30 minutes because it seems like it just went like that.
Yeah. Well, I mean, it's a wonderful takeaway to anyone who's watching that each of us can play a role in reducing that stigma, regardless of our kind of relationship to lung cancer and to smoking.
Yeah.
Lisa, I want to thank you for taking the time to talk with us today. It's really honestly inspiring to have a healthcare provider who is so compassionate about the patient perspective. I know that you're having an influence on a lot of other people, and we're all grateful for the time you took to talk to us today.
Thank you for the opportunity to highlight stigma and the importance that we need to address it with both healthcare providers as well as patients and the public.
Absolutely. And on that note, we actually want to let the audience know that we have events such as this that are going to happen every month, first Wednesday of the month. So keep an eye out for upcoming events on our Facebook page. And also remember, you can join Health Stories Project anytime. Anybody who has a health condition, healthstoriesproject.com. Join us next time, and we appreciate you spending your time listening to today's discussion.
Thanks.
Great. Thanks so much.
Have a great day.
You too. Bye-bye.